Hello, everyone. Welcome back to Dental Expert Talks. And we are close to 50 episodes now since the lockdown. And we've been taking all kinds of topics, right from our dental topics to COVID related topics. And as we know, COVID has been playing havoc in India. In this second wave, we have again come back with another COVID topic. And black hot topic which we have right now is Mucor Mycosis or black fungus, which we all want to know about. I want to start the session with a small incident which happened in my clinic last week. And one of the patient whom we were supposed to do extraction and immediate implant, he calls me up and he says me, look, I have been hearing about this black fungus which affects the bones in and I think I should be postponing my dental treatment. I was like, why? What happened? So he's like, no. You dentists are involved into it, and I don't know if I get some infection because of that. And I'm worried this is related to bones, and I want to. I tried explaining him, but we know that there's no point in convincing this kind of cases. I just tried to give him the scientific background so that he doesn't go and spread something wrong. But we will not pursue this patient. We said, okay, fine. Whenever you feel okay, we will continue with the treatment. So that not only we as dentists, we have a limited knowledge about this, but even the patients also need prior education. So let's start with a talk show where we have two guests today, Dr. Nishit Agni, who is oral maxillofacial surgeon, and Dr. Manoj Chawla, who is a diabetologist. So naturally, our surgeon friend, Dr. Nishit, is going to talk about the surgical care of it, and Dr. Manoj Chawla will help us to know us more about the medical care of it. Let me introduce both of them. Hello, Dr. Nishit. Hello, Dr. Manoj Chawla.
Hello. Hi. Thanks for having me here.
Thank you. So, Nishit, I know since 1998, 99. So, Nishit has been my junior in Government Dental College, Mumbai, and I know him since then. A naughty but a sincere student he was. And these kind of students are better surgeons. We all know that surgeons have to have that little extra naughtiness, right? So, Nishit did his BDS, as I said, from JTC Mumbai, and then he did his MDS from Sharad Pawar Dental College, Savangi, in the year 2008, and has been practicing and has got multiple attachments. Like he's honorary oral maxillofacial surgeon at Valavalkar Hospital, Cheplun, then panel consultant and maxillofacial surgeon at Surya Hospital, Santa Cruz West. Then Sterling Hospital, Borivali West in Mumbai, and Sri Ganesha Multi-Speciality Hospital, again Borivali West. Zenith Hospital, Malad, and Oscar Hospital, Kandivali West. And he is director of Cleft Center, Mumbai. And he's done a lot of work in cleft lip and palate surgeries, which I can see. Multiple honorary attachments pan country, and part of cleft lip palate craniofacial surgeries, orthognathic surgeries, maxillofacial cosmetic surgeries, maxillofacial trauma, TMJ open and orthoscopic surgeries, and so on and so on. And he has a lot of research papers on his name. I think the list is endless, meaning if I start saying that, probably I will be talking about that for maybe another 15 minutes. And now Dr. Manoj Chawla, he's a very reputed diabetologist from Mumbai. Dr. Manoj has completed his MBBS from Topiwala National Medical College, that is medical college, that is Nair Hospital, and I did my MDS from Nair, so that's my post graduation institute, and he did diploma in diabetology from the same institute in 1997. He is consultant diabetologist at Lina Diabetes Care, and he's coordinator of Department of Diabetologist in Asian Heart Institute. He's honorary diabetologist at SL Raheja Fortis Hospital. Then he's faculty at D.Y. Patil Institute of Medical Sciences, Navi Mumbai. He is honorary diabetologist at Mahavir Medical Research Center, Khar West, Arogya Nidhi Hospital, which is in Juhu. Then he's the course trainer in National Diabetes Education Program. And again, a lot of leadership positions which he has since 2008, that is president of United Diabetes Forum. Then he's trustee of Mumbai Diabetes Care Foundation and executive member of Technology Committee of RSSDI India, and executive committee member of Maharashtra State Chapter of RSSDI, and so on. And awards and recognition, he is the recent one, which I have to say that he's now got fellowship of Royal College of Physicians of Edinburgh in 2019, and so on. So both of them have very rich experience. And Nishit, to begin with, Nishit will give us a small presentation, a PowerPoint presentation of say half an hour, and then we will proceed for the panel discussion. To begin with, Nishit, as far as I know, that most of the oral surgeons have those few cases in their kitty, which they do once in a while, one case in few years of mucormycosis, right? And you do a surgical management, and suddenly in last few months we've been seeing a major surge of this kind of surgery. What you did in years, you've been doing in days and weeks.
Very true.
Right. Yeah.
Mucor is an age-old disease.
Yep.
But it used to be very rare. With COVID, suddenly times have changed.
Yes.
With places like Gujarat, if you speak to fellow surgeons, they say they're operating 4 or 5 cases a day.
I know.
Even endemic areas like Tamil Nadu and Salem, some places, it was endemic to those places, probably due to the lifestyle, say their climate, whatever it is.
Exactly.
So, speak to senior surgeons there, they say they used to operate around 7 to 8 cases a year, and now they talk of days.
Yeah, absolutely. So why don't you share your screen, and let's start with a presentation from your side. Let's go through the presentation, a formal presentation, and then we will have a panel discussion.
Sure. One second. Okay. Okay. Friends, I'll be speaking on mucormycosis, a dentist perspective. Here, the tagline is to be watched, a diagnosis we cannot afford to miss. Because a lot of cases in case of misdiagnosis are going to lead to larger problems for the patient. They can't get timely surgeries done, they can't get timely attention, and they risk losing a lot of organ and sometimes their life. Now, mucormycosis is a rare but serious and sometimes a lethal fungal infection that's caused by a group of fungi, especially molds, called mucormycetes. The most common in that order are Rhizopus and Mucor species. Now, these are non-pathogenic to begin with. They are saprophytic, that is soil fungi, and they are associated with decaying vegetable matter, decaying organic matter, manure for that matter. Okay, it is usually found in bread molds, the moist soil, rotten wood, compost, even the black fungus that you see on rotting vegetables or fruits in the house is most of the time from the same group, or even the fungus that grows on your bread. Now, all these fungi are basically there in the atmosphere. They're probably surviving with us in our day-to-day lives. Now, coming to mucormycosis, which is an infection with the fungal species Mucor. Now, it was initially known as zygomycosis. Now, this term has been largely replaced by mucormycosis, although sometimes it is reversibly used. For local parlance, it is used as called as a black fungus. So you'll have black fungus all over the news today, mostly caused due to inhalation of fungal spores. So these fungal spores are released into the atmosphere, and on inhalation, they go and sit into your sinus mucosa. And in case of low immune count or some reasons that we'll be discussing in the later part of our presentation, they lead to a fungal infection. It carries a very high morbidity and mortality. When we say high morbidity, there is a lot of organ tissue loss in these cases, and mortality, we know it's usually 30 to 50% of the patients succumb to these infections. It is a highly opportunistic infection. So we know when we say opportunistic, we are talking of infections in case of patients' immunity being low or immune suppression. Now, there are different types of mucormycosis infections. The ones that we as dentists are bothered about is the rhino-orbital cerebral mucormycosis, or rhino is the nose and the sinuses, orbito is your orbit, and cerebral is obviously the brain mucormycosis. Cutaneous and soft tissue mucormycosis, which is acquired through cuts or bruises in your skin, and then that getting contaminated by soil which has spores of these mucormycosis. And then there is a fungal infection. Or soiled bandages, unclean, unsterile bandages. Pulmonary mucormycosis also from inhalation. Gastrointestinal mucormycosis from ingestion of food infested by these spores. Mucormycosis of bones and joints, and disseminated mucormycosis, which usually is more like a terminal stage. Now, what are the predisposing factors? We said it's an opportunistic infection, so it has to have some predisposing factors. So it could either be an immunocompromised host or an immunosuppressed host. So when you say immunocompromised, the compromise is through some disease. Maybe it could be an HIV/AIDS infection, could be diabetes mellitus, could be stress hyperglycemia, which is newly found with COVID-19, renal failure, severe burns where there is a lot of tissue destruction, hematological malignancies such as leukemias. In case of immunosuppressed host, they are those who've probably received an organ transplant or post-organ transplant, are put on medication so that their immune response is kept at a lower level so as to avoid organ rejection, or a long-term steroid usage in high doses. Now, usually steroids are being used by rheumatologists to manage rheumatic pain, arthritic pains. But suddenly with COVID, steroids are being used as life-saving drugs. And there is some amount of steroid abuse as well. So when there is a large dose steroid usage, which goes on for a long time, it's going to suppress our immunity drastically, making you vulnerable to these opportunistic infections. And immunomodulation drugs such as tocilizumab, sarilumab, they are used in response to systemic inflammation or the so-called cytokine storm. Now, these drugs are so commonly heard by people on news saying that they are not available. And so I think most of the people are familiar with these drugs. Now, what is the eco-pathogenesis of mucormycosis? How does it actually spread? So it has to start with an immunocompromised host. Now, this immunocompromised host is going to inhale fungal spores. They go and settle into your sinus mucosa. There, because your immunity is low, they cannot be tackled by your immune system, and then they develop an infection, a fungal infection, or the mucor fungus infection. Now, the fungal infection means they are going to multiply. The fungal septae typically work with a phenomenon of angioinvasion. So angioinvasion is they invade into your blood vessels. So the moment your fungal hyphae invade into the blood vessels, they are going to block it, right? Once they block the vessel, your blood flow is going to be sluggish, which is going to lead to more amount of coagulation. So vessel occlusion, finally the vessel gets occluded. Once it is occluded, there's no terminal blood flow. This will lead to necrosis of the tissue. And this necrotic tissue is going to pave way for secondary bacterial infection. And it is going to increase the fungal load because now your white blood cells, your antifungals, whatever medication you try to give to the patient is not going to reach the necrotic part. So what is the current scenario? Why are we actually sitting here on a Sunday evening discussing mucormycosis? Now, we are now facing an endemic in a pandemic. You already had COVID-19 as a pandemic, and now mucormycosis is a new, freshly derived endemic in this. So you have a drastic rise in number of mucormycosis cases post-COVID-19. So after the first wave, there were cases, although it was not as widespread as the second wave. And nobody knows what exact etiology factor is playing a role, but it surely is multifactorial. That is one. Although there are various hypotheses which I'll be enumerating in the next slide, there's one common variable to all of these, and that's immune suppression. Now, what numerous hypotheses have been put forth? One is due to hyperglycemic status in COVID-19. Is that true? High dose long-term steroid usage? Yes. Due to immunomodulator drugs used for cytokine storm? Due to zinc and iron overload in the body? Because it is found that iron is essential for mucor to grow. Okay. Due to possibility of the virus causing vessel occlusion due to abnormal clotting. Yes. Due to excess steam inhalation and use of home remedies. This is something new which people have started speaking about. But which is one single factor? Nobody knows. Because there are cases reported now where the patient is immunocompetent, patient is non-diabetic, patient has not had COVID-19, or probably he was not diagnosed with COVID-19, either of the two. And they have also been diagnosed with mucormycosis. Now, what is the dentist's role in diagnosis? Now, dentists are surely not going to treat mucormycosis, but they might be one of the first persons who would suspect mucor in a patient and then refer the patient to a specialist so that they can get early treatment. How is this possible for a dentist? One is you need to take proper history for COVID-19 infection or a COVID-19 contact or diabetes, the routine history, and these two extra histories. Monitor blood sugar levels before any dental treatment. Say extraction, root canals, because in case you think the patient can have a flare-up. And then refer to the specialist at an appropriate time. There have been instances where a patient has come for a certain dental problem, which technically is not dental, it is mucor related, and valuable time is lost because the dentists are trying to save the tooth, say by root canal or they just extract the tooth, and the patient feels that immediate pain or immediate thing is taken care of, and the patient comes back with fulminant infection. Now, what are the symptoms that we as dentists should be watching out for? One is a sharp, unexplained pain or a neuralgic kind of pain in the midface and the eyes, which you cannot explain. Sudden, unexplained paresthesia in the midface. So in the cheek, in the infraorbital area, the lower eyelid, the lateral part of the nose, typically the area that is supplied by infraorbital nerve. Sudden, unexplained dental pain. So patient complains of pain in the tooth. Usually that tooth has to be the first premolar or the canine area. That is where your sinus starts. So sudden unexplained pain, there's no cavity, there's no periodontal lesion, but the patient has a lot of pain. Now, in such cases, in case you say start a root canal and the pain does not subside in 2 or 3 days, or maybe the next day because the pulp tissue is relieved of pressure, it is a red flag. It has to alert you to a possibility of mucor. Sudden unexplained tooth mobility. A patient comes with a complaint of sudden tooth mobility, the teeth were all fine, and then gives you a subtle history of COVID-19 infection or a contact. So when there is no periodontal compromise or when you cannot explain the reason behind the tooth mobility, suspect mucor. And pus discharging sinus tracts may be single, multiple from gums without any offending teeth. Right? So we'll be seeing a couple of clinical pictures to show all these. Now here you can see that there is a draining sinus, pus discharge here. The adjacent tooth is RC treated. This tooth looks fine. There's no pain whatsoever on percussion. A GP point passed through the sinus doesn't take us to any apex of any tooth. And this is a patient whom I've seen 2 days back at a dentist because the endodontist said it probably is from the first molar and needs to be extracted. Now the patient gives a vague complaint, says there is a sharp shooting pain sometimes in the infraorbital area. So now this raises a red flag for me. So before I go ahead with an extraction or before I go ahead with any kind of treatment for her, the first thing that I order is a CT scan, a CT-PNS, to find out if there is an issue with the sinus. She is a known diabetic, although controlled. Multiple draining sinuses from the gingiva. Again, you should raise a red flag. I was talking of sudden tooth mobility, which cannot be explained. Here you see this is a patient post-COVID. And you see the teeth are literally grade 3 mobile. There's no typical gingival recession, no gum swelling. And here there you see a draining sinus. Look at the video a little. Yeah, there you are with a lot of pus draining out. Right. This is a red flag. This guy has mucormycosis, which is quite advanced because the maxilla is already necrosed. Similar one here, if you see, it's not just the tooth which are mobile, the tooth and the alveolus. Entire thing is moving. So it's already sequestrated. Abscess formation without any offending tooth. Here you are with abscesses in the mid-palatal area. Or you can have an eschar formation on the palatal or the buccal mucosa or even the skin. Now here the greater palatine artery is surely occluded and there is tissue loss in the palatal mucosa itself. This is eschar from infraorbital area. This is your skin, which is already necrosed. This patient did lose his vision and the eye as well. Now, this patient had come to me from Nasik, basically, 5 days post-COVID, with a very typical complaint of pain. Initially, he had pain while he was in the hospital. He did complain, but then probably nobody took him seriously. He was just prescribed a painkiller. And suddenly, after 5 days, he's come with a huge orbital cellulitis, infraorbital edema. For reasons best known to him, he got treated somewhere else. The guy must have done a decent job. Sometimes aggressive therapy, or rather, most of the times, aggressive treatment, aggressive debridement is the need. This patient has come back again with a recurrence of his orbital cellulitis. Okay, so he has probably residual disease, which was not cleared initially. If you notice that there is a maxillary hypoplasia, that means he's lost his maxilla. So this patient, we've done a nasal endoscopy, and you can see that there is a black eschar in the nasal side, nasal mucosa on the turbinates. I'm sorry, we've recorded it from the screen, so it's not very clear. There you can see the black fungal. We will see it in the other. This is the right one. Yes, this is the other one. Yes, this is your dark turbinate is already necrosed, and with probably the black fungus there. Now, this is a patient who probably has developed this osteomyelitis in the last wave. She had an extraction for some tooth pain in September 2020, followed by a huge swelling in the intraorbital area. And she's been to a couple of doctors, maybe prescribed some medication, not evaluated further. The swelling and the infection subsided, the patient forgot it. She's now come up with a huge sequestered bone, sequestered maxilla. And this is her Cbct. If you notice, this maxilla is already necrosed right up till here. There is some erosion of the infraorbital area, infraorbital rim. This is the normal turbinate on the left side. The right side, the turbinate is already destroyed. The ethmoid hair cells are already filled up with tissue. This patient has lost her eyesight on the right side, but probably she doesn't have enough, and she has a fully developed cataract, so it is not actually possible to see whether she has a retinal occlusion, central retinal artery occlusion. To come to radiological examination, the moment you have a red flag, you move the patient to a specialist, refer him to a higher center. Now, radiologically, we'll now discuss a couple of features that we would see radiologically. Say, in case a patient comes to you with a CT, Now, this is again, when initial stages, you will not see bony changes in a CT scan, except for just a sinusitis. As it advances, as the maxilla starts becoming necrotic and starts sequestrating, that means you have 30% decalcification in the bone. That is when your CT will start showing changes. So you see that the palate is already necrosed here. And both the sinuses are filled up, your ethmoids are filled up, right? This is another case where you see the sinus is filled up with tissue or with fungal growth. Here you have your lateral nasal wall, which is already eroded on both the sides. The same patient. MRI of another patient. MRI usually is used to detect soft tissue in the orbit. The orbit looks slightly distorted, but here you have more collection in your sinus. Everything has to be correlated clinically as well. Now, how would a dentist aid in diagnosing it? First, most important is clinical suspicion and a thorough examination and history. The moment you have these, you can always be the first one to diagnose, first one to suspect. Because if you don't suspect, you cannot diagnose it, right? Now, how do we diagnose it? We take a deep swab from the nose and send it for a KOH mount or a KOH microscopic examination where you can see the fungal hyphae. This can be done even as an outpatient procedure, can be sent to the lab, and you can receive the results in maybe 4 hours to within a day. So they will examine the fungal hyphae. Second is you can do a biopsy and send the sample for histopathology. It is the gold standard for diagnosis even today, because that is when you can see the fungal hyphae on histopathology. And the biopsy can either be endoscopic or open. Fungal culture can be sent so as to find out what fungus grows on the culture and accordingly institute your antifungals. But more often it takes probably more than 2 weeks, sometimes 1 week to 2 weeks to get a fungal culture report. And hence, most of the times your antifungals are started empirically based on your pathology and KOH mount. In case there is a single tooth mobility, especially the premolar canine area, and your patient doesn't want to go in for any further investigations at the moment, you could probably do a single tooth extraction there, if to confirm if the socket is bleeding or if there is bleed at the tip of the apex or at the apex of your extraction socket. If that doesn't bleed, there's a strong suspicion for osteomyelitis that has set in. That's when you need to refer the patient. Treatment, it has to be prompt and aggressive. You cannot just take it easy. Primary objective of treating mucor is to save life and treat early to minimize organ loss. So otherwise, the patient is going to lose maxilla or maybe the mandible, lose eyesight, probably lose life. It needs a teamwork. It's not a single man's job. Your team typically comprises of your maxillofacial surgeon, your ENT colleagues or otorhinolaryngologists, a neurosurgeon, ophthalmologist. Amongst the physician, you can have your general physicians, your diabetologist, most importantly, your infectious disease physician, who would then titrate his antifungal dosage. Now, most patients will need both medical and surgical management. Medical management, to begin with, we need to stop immunomodulating drugs, steroids, control the blood sugar levels, like for any other surgery, and institute antifungal therapy at the earliest. Surgical management will have to be aggressive debridement of necrotic tissue, soft tissue as well as bone. Now, I'll just be touching on the medical management. I won't be going into details because I don't think it makes too much of sense discussing medical management between us. Amphotericin B is the antifungal drug of choice, but it is highly nephrotoxic. So you need to titrate the dose vis-a-vis the renal parameters. Liposomal amphotericin B, that's a newer drug, which is less nephrotoxic. And it has an added advantage of penetrating the blood-brain barrier. So in case of cavernous serous thrombosis or a cerebral abscess or intracranial extension of the mucor, this could help to a certain extent. Oral antifungals, posaconazole, isavuconazole, they have already also been used to treat it. The current problem is crisis in getting these drugs. We come to surgical management, maxillectomy, partial, total maxillectomies with orbital exenteration with ethmoidectomy. So whatever is necrosed, you try and debride most of it. FES, functional endoscopic sinus surgery. Technically, it is not FES that the ENTs would do for this because we won't be doing functional endoscopic sinus surgeries. It will be an endoscopic sinus surgery to clear the sinus, or most of the times clear ethmoid and sphenoid sinuses, which are not amenable to open surgical procedures, or you need to really dissect far more to clear those sinuses. And second, an endoscopic approach is useful in getting tissue samples for biopsy. I'll be showing a couple of clinical pictures. It's not very nice to show such pictures. They're too grotesque. People losing their jaws, people losing their eyeballs, right? Similarly, a patient with a full-blown mucor involving the entire alveolus, the lower inferior part of your maxilla, the complete maxilla, the entire alveolus and all teeth were removed. Closure. We won't be trying to get too many photographs. It's very difficult to take pre-op, post-op photos for patients who are really traumatized with the disease. So you have a parietal eschar that I had shown. Again, this patient has lost one half of the maxilla and a part of the other half of the maxilla. Here, as I said, we can extract a single tooth and look for dead necrotic bone. Go ahead, open up, check. You can usually have some demarcation of avascularized bone and vascularized bone. There's a difference in the color, very, very subtle difference that you can see. And that helps us in removing the specimen. This patient has lost the entire maxilla. Similarly, this patient with the central disease is lost a part of his septum as well. You can see this black fungal necrotic bone, an entire maxilla being lost. So here, I think if you see these patients early on and refer them quickly, it'll be easier to save their bones. Now we come to complications of mucor mycosis. One obviously is osteomyelitis that we've just looked at. Second is blindness. This is the photograph of that lady that I just told you. She's blind on the right side. Pulmonary mucor. Now this is taken from a colleague. The patient was debrided but not put on antifungals. He has disseminated mucor mycosis in the lungs. Cavernous sinus thrombosis, cerebral abscess, and death. These three are really lethal, the last two. Now, how do we prevent it? Can we really prevent it? Well, we don't know if we can really prevent it as of today because we don't know the exact etiology of the disease. But then we can surely try to maintain as much hygiene as possible because we know fungal infections are usually there with lack of hygiene. So use clean masks, maintain personal hygiene. Now completely cover your body while working in the soil, especially gardening. Maintain good glycemic control. For medicos, we need to use steroids judiciously, use broad spectrum antibiotics, antifungals, immunosuppressive drugs. Use clean and sterile water in humidifiers. The new thing is use of methylene blue in humidifiers. Methylene blue does have an antifungal role, but how much of use it can be is yet to be studied scientifically. Early suspicion and diagnosis. There are cases where people have started using acetic acid for wash. Now they are known to be used from ages for doing wound dressings. Now, very specifically for mucor, once you've already done debridement, most of the times early debridement, and if there is no, if your mucor is not crossing a blood-brain barrier, there's no intracranial spread, there is a possibility that the patient's life gets saved. So how much of value are these things adding today after debridement is a question. We need something which we can use to prevent it. So currently, what I can see is early suspicion and diagnosis as the mainstay to reduce the load of mucor mycosis. Special thanks to my friends for their help and inputs. Thank you.
You can stop sharing the screen now.
Yeah.
Thank you for that quick and very valuable insight of the disease. And we all really wanted to know all these things. And as I can see, the things are like evolving almost every day. I mean, every day we come to know something new about it. Like as you mentioned, a role of acetic acid for to avoid the mucormycosis is something which is shaping up recently, right? So, Dr. Manoj Chawla, we would want to have a medical input on this. Meaning, there have been a lot of theories which we all have been listening to, right from COVID to immunomodulators to immunosuppressant, which are used in COVID infections to diabetes, of course, is probably the major factor, to steroids, to zinc, to iron. Everything has been discussed so far. To uh, oxygen concentrators. So, what is your view on this? And can you, Dr. Manoj, can
You are muted.
unmute?
Right, sorry. Yeah. Okay. So to begin with, let me congratulate Doctor for that wonderful, comprehensive talk on Mucor, and I'm extremely glad that I didn't take up any assignment for slide presentation because there was nothing really more to add to it. So he's beautifully shown the entire picture, and he's working in the thick of things. So many congratulations to Dr. Nishit. Now, in terms of what really are the reasons, I think again have been covered very well with Nishit. We really don't know. The simple answer is we really don't know what is the exact cause. There are a lot of things which have been postulated and possibly implicated, but we don't know the definite answer. Is it seen more in people with diabetes? Yes. But of course, there have been instances where patients have not had hyperglycemia as well. Is the postulation that this is because of weakened immunity? And hence, traditionally, this used to be seen in patients with diabetes and deep diabetes ketoacidosis. So this would be listed as one of the complications in patients with DKA. But extremely rare. So it's something that has been around for the longest time. In fact, the earliest description goes back to almost 130, 140 years back. I think 1885 or somewhere around that has been the description of Mucor Mycosis. But in my last 22 years of even training at Nair, then Raheja, and then in private practice, I've barely seen 2 to 3 cases. So it was something which was always dreaded and probably always carrying poor morbidity and very often mortality, but it was extremely rare. But the numbers that we have seen now in this second wave post-COVID have been extremely baffling. So we really don't know, is it poor hygiene? Is it the nasal prongs? Is it the use of non-sterile water? Is it the strain itself which is responsible for causing it as shown, whether it's the cause of more thrombosis? Is it the increase in ferritin levels? There is some postulation whether increase in ferritin and iron, which is happening as part of this COVID, could also be the reason for growth of this fungi. Essentially, we need to remember that this is not a different or new fungus. It exists all around us. It's there in the soil, it's there in the air, it's there in compost, it's there in all waste material. Very often, I mean, it's there in your house. Your fruits, which go black, is nothing but the same black fungus. It's there with us in our human body itself. It's just that we filter it away. It's only when you're immunocompromised, it's able to break your that immunity, break your that defense, and enter in the manner that it does to become the systemic disease and the spread. So we really don't have the final answer that we have all these postulated reasons, but the fact is it's there. And it has to be picked up and treated in a high index of suspicion by any medical, dental, any paramedic for that matter. I think that's what is going to help us make this better.
Exactly. So as we all have been reading, there used to be an uh, initial articles which used to say that oxygen concentrators are leading this, and the dirty water which has been used in. Now we know that water as such is not a source of fungus. Of course, humid air leads to growth of fungus faster. We all know that, and being the monsoon coming up, we all know that the dry weather doesn't really have fungal infections much, whether it is there in the air or at home, or the fungal infections like skin diseases and all, uh, or the humid air or humid weather definitely leads to. We all know about. But do we have had summer, right? Like it's not really humid as such, except for the city like Mumbai or the coastal cities. Meaning it is little strange. Probably humidify oxygen concentrators. Doctor, do you know that oxygen concentrators have been used in medical science for like really long? It's just that the use has become very common now with COVID. But there used to be an incidence with oxygen concentrators even in the past.
So, Ajay, is of course the kind of oxygen concentrator and oxygen humidifiers becoming a household name which happened now was not a thing of the past. But again, you had many patients who had interstitial lung disease, fibrosis, those who had issues with their lungs. During this entire shortage, there were so many times that we spoke to patients, some of them also in different cities like Delhi, and who said that somebody in house was down with the COVID, but fortunately they did have a concentrator because one of the parent used to use it earlier and not survived over the years for whatever reasons, and they had a concentrator at home. So people with lung diseases have been on concentrators. They've had comorbid diabetes, they've had severe hyperglycemia, and they've had chronic use of steroids for reasons of their interstitial lung disease. They did not land up with Mucor. You hardly had any documented evidence of patients on long-term steroids, whether they were used for arthritis, they were used for their lung conditions, they had comorbid diabetes, they were on oxygen concentrators. We've not had this kind of documentation anywhere. So as I said, it's there, and I wish we had the answer as to why this is happening, because unless we get that, we'll never really be able to reverse that main cause of things. So I think it still remains an enigma as to why this surge, and these are only all postulated beliefs and theories that we still have in paper.
Exactly. So there is a question, and a very important question from one of the dentists is why mucormycosis is mostly seen in maxilla and not that often in mandible. This is for Dr. Nishit.
We've already mentioned that mucormycosis technically spreads from inhaled fungal spores. So when you inhale fungal spores, they're going to go and get lodged into your sinuses. That is the main reason why you see mucor in the sinus or in the maxilla. Mandibular mucormycosis is also seen. I have seen a case with mandibular mucormycosis, a mandibular osteomyelitis rather. We can't just term it as mucor unless it's proven to be mucor on histopath. But then that's the main reason. Secondly, once lodged into the sinus, they go and block your terminal part of the maxillary artery, or the third part of the maxillary artery, your intraorbital, your posterior superior. So these vessels get blocked, and that is the reason they cause avascular necrosis of the maxilla. So it starts faster that way. That is why it is more prone to the maxilla.
If I can just add to that, Nishit.
Yes, sir.
So one, we need to also understand that amongst the more prevalent ones of mucor is the rhinocerebral mucor mycosis, which is what we are discussing here, and Nishit referred to, often affecting the maxillary with the chances of thrombosis of the cavernous sinus or the internal carotid and even the smaller arteries.
Yes.
But there are other variants of mucor as well. So, which of course we are not seeing. There is a GI mucor, there is a genitourinary mucor, but of course they are again rare. Right now, again, everything that you're seeing seems to be rhinocerebral, and which is why one of the beliefs that is it this particular strain, which also has an affection of the lungs and has the nasopharyngeal route, itself being responsible for more mucor than the traditional reasons that were there documented for mucor mycosis.
Okay, so Dr. Manoj, we all are dentists. Okay, so we have probably no knowledge about GI mucor or
Untitled or the other parts. True.
Yeah. Yes. Do you think any rise in cases over there as well?
No. So it's predominantly this one.
Okay. So there's practically no difference in the percentage of cases which you see in those areas, right?
No, there hasn't been a rise in those. They were extremely rare. They're just that there are those other variants of mucor that we know exist in literature, but not that we're seeing any rise in those.
Okay.
So there has been a rise in avascular necrosis of terminal limbs, which have been reported, especially in Nagpur. I was discussing it with a colleague. We were having a discussion on our group today. So they have seen people post-COVID who've come with necrosis of fingers.
Okay.
So again, I think it's essentially
to do with the COVID.
The procoagulation scenario that COVID is causing, the clotting is responsible for any kind of thromboembolic diseases anywhere in the body. So essentially, we understand that COVID is an inflammatory disease. It's a thrombotic disease, and hence the only validated treatments have been antiplatelets, low molecular weight heparin, and steroids.
Yeah.
Absolutely. So there's a question of, is there any protocol or is there any waiting time period to go for any oral surgical procedures like disimpaction or post-COVID patients to avoid any mucormycosis-like infections? Meaning, in short, probably, do you think that if somebody has gone through COVID and do we avoid doing any dental procedures or surgical procedures for that matter? Dental surgical.
It's not about avoiding. It's about investigating the patient before going in. It is not your drilling of bone that's going to cause mucor unless and until you don't have sterile instruments.
Yeah, absolutely.
But you go in, like I said, you go in with a, there have been instances where patients have come saying they have toothache. The tooth looks absolutely fine. There's no sort of decay. There's no periodontal issue. And then the dentist has wasted time doing a root canal, waiting for it. So even if you've opened up a root canal and the patient's pain does not subside the next morning, you suspect mucor and send in. Or if you want to do a say an impaction, get a CT done. Just because look for other signs and symptoms which should raise a red flag. It is just that not that you avoid doing a procedure. Say a patient comes with severe pain, a decayed molar. You can't tell him you had you had COVID 2 months ago. Now I'm not going to treat you. But then one thing that you can think about is, since he had COVID, he might have some deranged sugar levels. So get him investigated thoroughly before you jump into the surgery.
Absolutely.
So as to avoid, it's necessary from a medico-legal viewpoint as well.
So this is one question that I have to you, and the number of cases that you've been seeing. Of course, I'm assuming all of these are documented, proven histopathologically mucor cases.
Yes.
Right?
Yes.
What is the pattern? How much time after their COVID detection are you all detecting them?
So usually in the first 14 days, like patients who've come have come in the first week as well. And there are cases who are still COVID positive, diagnosed, and in COVID wards have developed COVID mucor.
Yeah. So essentially, it's something more to do with the disease rather than just the treatment.
Yes. So most logically, if I have to think, if we know that COVID does cause thrombotic events, so that might be the primary etiology where you have already thrombosis, immune suppression due to COVID, and then a secondary colonization by mucor. This is the presumption that I have in my mind.
So also there were some reports and some believe that even though cities like Mumbai may report that there were so many here, or cities like Ahmedabad or Delhi, but a lot of patients who were actually coming in for treatment for mucor were not from the city, but more from the rural areas who were coming down. So is that true?
It's everywhere, sir. It's everywhere. I spoke to a friend in Aurangabad. He says, no, now it is reduced. Now I operate 2 cases a day. Previously, I was doing 4 cases a day. So mucor has become rampant. And there are instances where you have as I said, immunocompetent patients, non-diabetic, non-COVID, and the patient has come with mucor.
Non-COVID as well.
Non-COVID as well. Or they could have had
not
maybe
known COVID or not detected yet.
Undiagnosed COVID.
Yeah.
So that is something which will not be able to diagnose now.
Yeah, exactly. So I think there was an article in Indian Express which said that out of 411 patients, 69 patients were not diagnosed with COVID. Meaning that could be only 211
asymptomatic COVID. They could have asymptomatic COVID.
Exactly. Only 50% of the patients were diabetic. So there was a lot of course, there are some common factors which we've seen, and more than half of the patients again were not given any steroids. So we do see some patterns. Do you think what is the protocol for the surgeries? I have one article in front of me which is written by one of the eminent oral surgeon. He says, wait for 3 months. Don't be so aggressive. Wait for 3 months to do the surgery. Whereas most of the other ENT...
So which surgery are we talking of?
The surgery where you are going to do maxillectomy or...
So I think debridement will have to be extremely urgent. So I mean, the principle of management is debridement at the earliest. So.
I do understand this, that you need to do earliest debridement at the earliest because it's a dead bone, it's a sequestrum, and it is not going to grow back again. And it has to be removed. There is no blood supply. Even if you use amphotericin B or whatever,
no, that's not going to reach.
Exactly. It is not going to reach over there. But this is some article which I have in front of me. So I thought I'd just ask you.
I think, Ajay, that the issue is that it's the early debridement is the principle to save as much as possible. Unless you debride, as doctor said, that your amphotericin B is not going to reach. So you have to take out what is there to prevent further invasion of the disease. So that's as needful.
Plus, you're going to leave some substrate for the fungus to grow, more aggressively.
Absolutely. Absolutely. So the next question is, how do we clinically differentiate between mucormycosis and aspergillosis in a COVID recovered patient?
You can't diagnose it clinically. Has to be histopathology.
Exactly. So the usual differential diagnosis is between aspergillosis and mucor. In current times, when you see that, you're going to assume it is mucor. You're not seeing much of aspergillosis. At least in the Indian country setup, you haven't seen as much of aspergillosis. You hadn't seen much of mucor also, of course, earlier. But that's a histopathological diagnosis. And there are some other variants clinically. In aspergillosis, you're going to have probably neutropenia and lymphopenia. Whereas in mucor, you're going to have very often leukocytosis and presence of active infection as inflammatory markers. So there are some subtle clinical markers, so to say, but I agree with Nishit that it largely has to be a histopathological diagnosis or even a good radiological diagnosis with a confident radiologist saying that.
So can I add something?
Yeah, sure.
Aspergillosis or mucormycosis, the primary debridement treatment is not going to change. It will only change the antifungal of choice. Aspergillosis, you would probably go with itraconazole, and if it's mucor, you will be looking at amphotericin B.
So, yeah, absolutely. Whereas amphotericin can work for both, but you may
but it's highly nephrotoxic. It's highly nephrotoxic.
Yeah, exactly. But amphotericin B as per se, or amphotericin B liposomal is supposed to be less.
Liposomal is better.
Is that right, Dr. Manoj?
Yes.
Sorry, can you repeat the question between liposomal and non-liposomal?
Yeah.
Yes, exactly. I think the liposomal is a less nephrotoxic, right?
Exactly. So liposomal is more effective, less nephrotoxic, and that is the preferred one. Again, just to give some trivia out here, we didn't have amphotericin B till 1953. So though the disease has been documented from 1880s, mucor in the past would mean death. There was really no treatment. just surgical debridement also wouldn't have helped. It was, I think, in the mid-50s that this credit was given to two scientists, I think Dr. Charles Smith and Dr. Wynn, who actually developed the drug by getting soil from Venezuela. So the specific region in Venezuela, there was some soil, and they found that had properties to grow amphotericin B, and that's the history. So the treatment has been available only for last 60, 70 years since then. But clearly liposomal is the one which is less toxic and more effective.
We hope that there is sudden rise in the cases and there is sudden rise in use of amphotericin B. We just hope that there should not be any resistance to sudden rise in resistance to amphotericin B.
We don't know, Ajay, it's a new word. Anything that you may say may just happen and may be held against you.
So, and we will be in another soup, unfortunately, that if something like this happens. So it's just that we're just hoping something like this should not happen.
That's the reason you're not having availability, you see.
Yeah. Meaning, I was seeing the official figures from the government. 2 days ago, there were around 12,000 cases in India requiring this, and they require 4 to 8 vials every day. So even if I consider, say, 5 or 6, so they require 12,000 is the official figure. Unofficial figures with the private practices and all probably not reported. So we require close to a lakh of vials every day, and that's a big number. So even if you see that they have imported 50,000 or so, that is not even going to be sufficient as half deca dose. So it's absolutely a major shortfall. So doctor, just in case if somebody is just not getting amphotericin B, is there no treatment otherwise from medical point of view, or there are some antifungals which can still be used to pull on the time?
So amphotericin B is the clear treatment of choice. The other options, as shown again, I think in Nishit thing, was posaconazole and similar drugs there. Yes. I still find it a tongue twister. That is isavuconazole.
Isavuconazole.
Right. So these are the options. Of course, with proven one, the surgical debridement is always going to be helpful, and treatment of the underlying condition and the contribution. So if it is hyperglycemia, if it's steroids where you can bring that down, of course, managing. So largely it has been, though we see some cases now in non-diabetes, traditionally, and even here the largest number has been in patients with uncontrolled diabetes. So, which is why we are not really clear as to what is the cause of this. In a lot of patients, it still is uncontrolled hyperglycemia and unmonitored use of steroids, right? So I'll share an anecdote, and I was surprised, and I was actually mad at a patient couple of mine who met me yesterday and day before, and they saw me after a year and a half, and they said, typically people will come and then suddenly in the middle of the conversation they will say ki September October mein COVID hua tha. I said, okay, fine, are you all right? You recovered at home? You had to be hospitalized? No, recovered at home. And I said, so what kind of treatment? So I've been making it a point to note down whether treatment was done at home or in the hospital, and whether steroids were used or not, amongst other things. And the patient said, yeah, but you know what? Who treated us? Her cousin, the wife's cousin in New York treated us. I said, oh, how nice. Wonder if we can treat the patients out there sitting from here. So good that the cousin from there could treat. And I was being extremely sarcastic of that. And I said, why? So said, because you know what, doctors here were just giving azithromycin and other things, and the cousin there said, no, that is not right, and you should take steroids. I said, okay. I said, and did you have high fever? Did your oxygen drop? Was there a D-dimer done? What was the CR? People are, no, blood test was done, not needed. The doctor there just said, just take steroids. And it's only in our country that, somebody from outside sitting there with no legal authority or license can advise from there, and our people can walk into the pharmacies and chemists and buy steroids. Right? Extremely ridiculous. And that's the sad state of affairs, that even though it's our own colleagues who are sitting there, sitting pretty in the US or UK, and felt so much of sympathy and empathy for their brethren in this country, and thought they could telephonically order drugs which can be bought from here from the chemist. So I think that's a sad state. somewhere all of this has contributed.
Yes.
So, absolutely unwarranted, undocumented in reports and haphazard treatments could have added to the mess amongst other things that we are seeing now.
Yeah, we have seen so many videos on YouTube as well as on WhatsApp and all by eminent doctors, even from India, who have been asking, okay, the treatment, the cheapest, why are people going for expensive treatment? The cheapest treatment is steroid. And once you know that you are into COVID, everyone should start with steroid. When we know for any viral infection, when it is in active stage, initial first few days, we should not be on steroid. If at all, if the steroid should be started in a later, maybe after, they say after 7, 8, 9 days of the symptomatic disease, then you should be starting, which probably that protocol was not. Even I got COVID positive in September, and the first medicine which was written for me was azithromycin. As a doctor, as a dentist also, I realized कि okay, मुझे तो antiviral नहीं है, ठीक है, but why to start with azithromycin to begin with? So probably after 4-5 days or so, do you think more use of antibiotics also have led to this? Because we know that if your antibiotics have been used for long, or misuse of antibiotics leads to superinfection, and one of the superinfection is fungal infection. Do you think that could be one of the contributing factor?
I don't think so. I'm not sure. So there has been use of antibiotics, but typically the antibiotic use was limited in most patients to 3 to 5 days. Really, I mean, whether it was azithromycin or doxycycline, how often have they been used even otherwise for regular common coughs and colds? It's, we keep saying these are virals, don't take, but I think that's been an habit because of liberal availability of antibiotics in our country, that everybody would just pop in an antibiotic. Forget even azithro and doxy, which are used now. I think Augmentin has become almost like paracetamol for people to take it.
Absolutely.
The regular cough and cold. So where did that land us up with any fungal infection? How many of us would have taken course of antibiotics for a regular throat infection over the years? Plenty, right? So I don't think though I speak against the non-controlled availability and use of antibiotics in our country, but I don't think that has been responsible, because it's been used, but not to that extent that would be responsible.
Okay. I was talking to a pharma company director, and he just told me just a couple of days ago that a COVID wave for them has been an antibiotic wave in their terms, because there has been increase in the sale by 125%. That's massive, meaning that's massive. They do have seasonal sales now. Typically come rainy season, there will be increase in whether it could be stomach infection or it could be viral infection or whatever. But they say that they have seen a massive increase in the sales of antibiotics. I know some people over here who were prescribed both doxycycline as well as azithromycin. I did not understand the logic behind it, but they were they were written both antibiotics.
True.
Together for like 10 days, 12 days, 15 days.
So Ajay, some truth in that, and I think what you just referred to in terms of rise in sale of antibiotics and that. I think largely that's been again the uptake in the rural areas. I think in the cities, as I said, it's been abused by many of us and patients throughout. It's in the rural aspects where patients really normally don't, for mild cold, coughs and fevers, may not even go to the doctor there and would do some home remedy, and they would actually respond because a lot of this is viral. But because of the fear of this being corona and other things, I think the usage overall has increased. My point in saying that it hasn't been overused was in terms of days. So people have used it, but for 5 days and so on. So not really sure how much of that would have changed the scenario.
Okay, great. So there's a question which says that please confirm the preferable time at which amphotericin be started. So when should amphotericin be started? I think as early as possible.
Immediately. The moment you can confirm your diagnosis on a KOH mount, the next moment you start your amphotericin.
And as soon as you get it.
As soon as you get it, that's the...
Yeah,
That's
that's valid. That's absolutely a valid practical reply. So, what is the difference between chemical molecular structure of liposomal amphotericin B and amphotericin B, which favors effect on kidney? I think this is beyond
Yeah,
the
beyond, and it's
scope of
actually
our
not different
lecture.
in the structure. It's only the way when you say liposomal, it is more
lipid
fat
soluble.
soluble, and it is
Lipid
more
soluble.
less toxic. So it's the same drug. The chemical structure is same. It's the way it is um, in the medium that it is made, which makes it less toxic.
Okay. So, what precautions and tests to be prescribed for the tooth extraction? Do you think for some time we should be, even for a simple procedure like tooth extraction, we should be going for some blood tests?
So if your patient gives a history of COVID or a COVID contact for that matter, a lot of, unfortunately, a lot of patients here, if you ask them for history of COVID, they say, हमको वैसा COVID नहीं हुआ था. Slight fever I had for 2 days. So they probably were asymptomatic COVID. So in that case, at least a basic CBC and a random sugar, if they have not taken any treatment for COVID, is mandatory. You never know, your patient might have deranged sugars. That is one. Dr. Manoj wants to say something.
No, sorry. Go on, Nishit. I'll add after you finish. Sorry.
Okay. And second, if the patient did have COVID, then there is and has taken treatment from a physician or was hospitalized, there is a high possibility that your patient would be on antiplatelet drugs. So then you add your clotting and bleeding investigations to it. And as I said, if you cannot find an etiology for to indicate an extraction for the tooth, then surely go in for a CT.
Absolutely.
So I'll just add to that. I think if a patient is seeing a dental surgeon in current times, that means there is a problem which is really bothering them in terms of pain is what gets our patients to see us, right? So
True.
If it is there, because a lot of people with routine issues are holding themselves or preventing themselves from visiting most doctors, including dentists. So the routine checkup people are not going to come unless there is something bothering them. And there's something bothering them, it does make sense to inquire and dwell into the history. And where you have enough suspicion, doing the swabs and doing the CTs, and of course the regular blood tests to rule out hyperglycemia and inflammation.
Absolutely.
So that's something that we even said, and that was in general to the entire dental community. A few months back, we came out with the paper with the Indian Periodontal Society. So RSSDI and ISP, Indian Society of Periodontology, we came out with a joint consensus paper on this bidirectional aspect between diabetes and oral health. And there's been clear recommendations there, again, reaching out to every dental surgeon about the need to keep at least a glucose meter, both to look at hyperglycemia and pick up hypoglycemia during active treatment in your clinics. Besides also, of course, recommendation to every physician, diabetologist and physician to start at least asking the patient to open their mouth and try and see in there, irrespective of how much we understand or not, but at least to start looking at any simple signs of periodontitis and asking our patients to visit the dental practitioner.
Great. So, Dr. Manoj, suppose from like tomorrow when I'm working in my clinic and if I have a patient which requires invasive procedure like extraction or some minor surgery, looking at diabetic point of view, even if patient says, oh, I'm normal, I'm fit and fine, I do not have any history of diabetes or what's it. So do you think there are some tests which I should be recommending him? I should be asking him to do fasting, PP or HB1AC, or what is that I should be telling my patients to do? The basic pertaining to diabetes.
Sure. So I think today a dental surgery is a surgery, Ajay. And I think it's time that one really change that, and especially in patients above a certain age, start asking for those minimum pre-surgical tests. Can an individual go in and get a cataract surgery done, which also today takes no more than 20-25 minutes in a good hand? Even a dental surgery is going to take 20 minutes or an hour or hour and a half, depending on the nature of the surgery, right? And of course, the route through the oral mucosal, I mean, if the barrier breaks and you have issues, you're going to land up with larger infection. So I think where possible, asking for your basic sugars and a blood count, and of course, in cases where required, your HIV and HbS-Ag as the pre-surgical workup should be done. We always today talk about what should be done in ideal settings and in limited resource settings. In limited resource settings, where whether it's finance or in other places, at least having a glucose meter, which you or any of your help in the clinics can use to do a random check for the sugar. Even if somebody says they do not have diabetes, well, you actually could be instrumental in helping a lot of people detect their hyperglycemia and then refer them to the physician with proper tests. So everybody needs to contribute here. We know today that's almost 12 to 15% of adult population does have diabetes. So doing that test is going to be helpful.
Absolutely. So my dentist friends who are listening to this talk, at least having a glucose meter in our clinic and doing a minors, it's a very simple test which we all can perform, or our clinic assistants can do, and we should be doing that at least right now for the time being, at least for next few months. We should be doing that in our clinic in order to rule out any frank diabetes that patient has. But just in case, if I have to write and ask the patient to get the test done, what are the minimum tests that you recommend, doctor?
BSF, BSPP, that is fasting and postprandial, along with the CBC.
Along with CBC. That is the minimum which you recommend. Okay.
In today's circumstance, yes.
Yes, absolutely. Okay. There's some questions which are repeats, so I'm trying to avoid them. Okay. So what is the longest gap between COVID infection and mucormycosis? After how long chances of mucormycosis are decreased in COVID patients? It's a very valid question. Meaning we just discussed that when is the first time you diagnosed, and as you said, the patient which you got from Nasik was like just 5 days out of COVID.
5 days out of COVID hospital, and he had pain while hospitalized.
Yes.
But then they said they gave him paracetamol and said, keep quiet.
They did not really bother to see him, because we can't really blame the system also, because
we can't blame the system because technically your eye doesn't see what the mind doesn't know. So you're not expecting it. And then suddenly, because when he came to me, he had from his left second premolar to the right third molar, every tooth, having grade 3 mobility. So he had lost entire maxilla.
Absolutely.
He still is left with his eye, is a good thing.
What is the longest period that I should be looking at? Suppose I have been COVID positive and I have all those factors that I am a diabetic, or I had hyperglycemia during the COVID times, or I have used steroids for some time during COVID treatment. What is a longer period of time I should be aware that I should be looking for the signs of mucormycosis in my own case?
So if I have to answer that, Ajay.
So what do you think? Yeah. 6 days, 8 days, 1 month, 1.5 months, 2 months.
So, it's a disease that we are learning more about, and a condition that we're learning more about. So honestly, what is the time gap that you should be watching out for? We really don't know. And hence, the awareness on such an aspect which are the typical symptoms as shown by Nishit, any of the patients, whether they are being seen by a dental practitioner, a medical practitioner, where anybody who's currently complaining of these symptoms, you have to have a high index of suspicion and then further delve into the history and do further investigation where required. Now, is this going to suddenly spring up 4 months after COVID or 2 months or 6 months? We really don't know yet. It's just that at this stage, we want people to be aware, not panic, not going to overdrive with thinking that every patient that you see with a pus pocket has to have mucor only. But keep in mind that that's a possibility as a differential diagnosis.
Yeah, absolutely. I think that covers most of the questions. And Dr. Megal, do we have any? Dr. Megal is coordinating with us and he's been sending us all the questions. Dr. Megal, do you think we have to cover any of the question which is left? Because this is a topic of interest for everyone and I should not be missing on anything that we want to know from Dr. Manoj and Dr. Nishit. I think we have covered most of the questions which have been asked by participants. It's been a great webinar so far. I think we covered most of the aspect, the surgical aspect and the medical aspect. And as Dr. Manoj has been saying again and again, that we all are just learning more and more about it. This is probably to do with the new variant or to do with the treatment protocol. We do not know. We know that there is a clear predisposition of mucormycosis in COVID-related patients, but that's not the only case. We are having cases which are non-COVID or non-diabetic or non-immunosuppressants. We do know that. So what is the common factor? Amongst all 100% cases, we do not really know as of now. But it was the same case exactly a year ago about COVID itself, right? We were trying to understand last April, May, we all were trying to understand the disease more. We used to see those videos coming from some of the countries where people are just falling on the road. And we were like wondering, are they fake? They probably were the cases of hypoxia. We did not even know meaning what exactly was happening. Now we understand COVID much better than that. Probably is the same case about mucormycosis. In next few months' time, we will have much more understanding about the disease. Thank you, Dr. Manoj Chawla. Thank you, Dr. Nishit Agni, for joining us over here at Dental Experts Talks, supported by Sensodyne GSK and Bombay Dental. Thank you, our viewers, for fabulous response and the questions which have sent us, which have helped many. Thank you so much. And I hope that this is a ways of as early as possible, and we did not discuss anything about it again in future. And we know things much better in coming few days of time. I hope we will get amphotericin B in a good supply. I know I get frantic calls from my friends, and their relatives are admitted in the hospital, and it is really, really difficult for us to see that they are not getting the medicine. They got dose yesterday and they're not getting dose today. They don't know whether they will be getting dose tomorrow. That is the kind of scenario people are facing. So thank you so much. And
Ajay, thank you. And wonderful to listen to you, Dr. Nishit, and keep doing the great work.
Thank you, sir.
Also, an example on a lighter note that keep telling the students now, the postgrads, that the fact that we're talking about mucor and fungal and amphotericin B, don't take anything for granted. Don't leave some topics and options in medicine and dental sciences. The world is changing. You don't know what is going to hit you in the years to come. So
very true. Very true.
Absolutely. Right. It's been wonderful being here and having a conversation with you guys. Have a wonderful Sunday evening.
Yeah, it was great listening to you as well, Dr. Manoj.
Right. Bye. Bye.
Thank you for the insights. Thanks
Bye-bye.
a lot, Ajay.
All the best.
Thank you.
Recording stopped.